Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Welcome to JVRD's Author Forum. I'm privileged today to have Dr. Paul Chan, Professor and Chair of UIC, joining us to speak about his presentation paper on serial OCT imaging of spontaneous closure of a pediatric traumatic macular hole. Welcome, Paul.
Thanks, Dr. Murray. Happy to be here, and thanks for the invitation.
Well, traumatic holes in young adults have been really confusing through our literature as to decide what to do. So I'd love you to take us through this case report.
Yeah, one of the reasons why we wanted to present this case, and I have to thank my co-authors, Dr. Andrew Tsai from Singapore and Dr. Kaufman, who's actually going to be a cornea attending, but he was one of my residents at the time. And the reason why we wanted to present this case was simply because, and Tim, you know this as a pediatric retina surgeon, is that traumatic macular holes in children are different. And I think that it's really important to highlight just how we have to be patient in a lot of these situations unless there's, other considerations. This was an 8-year-old girl who came to me after having seen a retina surgeon in the community. And this was about 10 days after a bungee cord injury to the affected eye. And what was interesting is that the mother said to me, well, does my daughter need surgery? Because that was what was being recommended. And they paused, right? They just wanted to make sure that they were doing the right thing for their child. And having said that, right, this is only about 10 days post-injury. Looking at the imaging and in this report, you can see that there's no choroidal rupture. There's no other indications there's no retinal detachment. So we decided to watch. And I think that this is a very important lesson for all of us to really highlight what can happen in children if you just wait.
So it's interesting because what that doctor had recommended would not have been inappropriate for an adult potentially, correct?
That's right. And I think that, again, like we mentioned, children behave very differently, right? And we have to take that into consideration. I think this is why this presentation and this discussion is very important. And there's still a lot that we don't know. We don't have comparative trials around, should you do surgery or observe. But what we do know time and again is that children do have this inclination to resolve on their own after trauma.
Now, did you offer any type of observational treatment while you watched this?
Yeah, that was another thing that was interesting. They already came in on a non-steroidal. But other than that, I wasn't going to recommend anything at all for this case, except just to watch them and see how they progressed. And I'm curious from your end, would you have recommended anything additional?
Yes, I think one of the things that's interesting is you and I would like this hole to close without requiring surgery. So anything we can do in a reasonable manner seems relatively appropriate. So we've been using dorzolamide in our children, looking to have some RPE pump activity to help us. Sometimes we will use a non-steroidal or a steroidal with that. And that, to me, also gives the parents the comfort level that they're doing something more than just watching. But, that remains very controversial, but it has been helpful for us in a number of cases.
Yeah, and I think we kept the patient on the non-steroidal. At the time, we did not try dorzolamide. We've done that in other situations. And what's neat about this, I think another important piece around this is making sure that you sit down with the mother and the child to show them the imaging. Right. So educational, and it's very impactful to let them know what's happening. And I think that's another important sort of pearl in these cases, as they see this hole evolve from a larger hole then to this metamorphosis to a smaller hole. Then there's sort of like this ERM or this intact vitreoretinal interface to the PVD, and then full closure, right? And this happened over the course of about 3 months.
And what's interesting is that you captured it so nicely. I think sometimes we'll see the hole open and the hole close, but that the transition as there is, impending closure of the hole, I think is nice. So looking at this in hindsight, how would you have watched that child with repeat imaging? Would you have stayed at the same schedule? Would you have wanted to see the child earlier? Any thoughts?
Yeah, I still think that about every month tempo is reasonable. Whether or not you want to go every 2 weeks and so forth. I think a lot of this is also going to depend on how the family is feeling, right? This is a conversation. Seeing someone more frequently isn't going to hurt them, and if anything, it may reassure them. As you go through this process. I think what we do know is that most of these holes, if they do close, will close within about 6 months. So that's the conversation.
So how long do you like to wait? So where do you start saying this is a hole and I'm not seeing closure and I need to think about going to the OR?
Yeah, and I love that I'm talking to you about this because I'd probably call you up and get your opinion. But for me, it's about 6 months, right? And that's what I told the family. I say, listen, we're gonna follow you very closely. If anything gets worse, we'll take you to the OR. Fortunately, everything was getting better. I think the other consideration is there anything else going on besides the hole, right? I mean, this is a bungee cord injury, right? And it was directly to the eye. Could there be dialysis that forms? Will there be retinal tears that form? Are there other issues? Another thing also that's very important is that there was no afferent pupillary defect, right? So we know that, probably the optic nerve is fine. We continue to monitor that. But I think for me, and again, I'm going to put this back at you, for me, it's about 6 months, but I'm going to follow them closely.
I'm not as comfortable as you are. So for me, typically it's 3 months.
Okay.
If the parents really pushed back, I would be willing to extend a little bit. But I think by 3 months, if I'm not seeing some indication that the hole is migrating to closure, I'm thinking that maybe they need to go to the OR. The other thing we look at with these kids, as you've said, is we'll use ultrasound also, trying to assess what the status of the vitreous is in this eye, whether there's a peripheral dialysis, because some of these kids are really tough to evaluate in the far periphery at this age. Some are wonderful, some are not. So just a thought about the quality of the imaging. And then the other thing I'd love is, so one of the reasons you and I don't like to rush to the OR is these can be technically challenging operations. This is not like a full thickness stage 3 macular hole, in a 28-year-old. So could you tell me a little bit about, if we had to operate, what would be some of your focused concerns?
Yeah, I mean, I think the biggest concern is, are you getting the hyaloid off, right? And that is the most difficult thing to do in these young children. And whether or not you have schisis cavities or vitreoschisis. So making sure that you're staining appropriately, making sure, one of the other things that we talk about too is using our instrument as a mechanical tool and lifting. So I think always making sure that you lifted the posterior hyaloid off of that central area, because I think that is a very important part of this.
And for holes like this, at least initially in an adult, most of us would be thinking about peeling the ILM, either with or without a flap. So what do you do with the ILM in an 8-year-old?
Yeah, I'd be fine not peeling the ILM in these children. But again, I think that's going to be very surgeon dependent. What do you do, Tim?
So for me, I like to get the ILM up. One of the reasons I like that is it tells me that the vitreous is fully elevated. There's no, if you take the ILM off, there's no hyaloid by virtual definition. So you get kind of that gift with purchase. But I think that what you've alluded to is there are so few of these cases that all of us take care of, that there's no randomized data. So you have to really look at sort of best case approaches. And that's what I love. I think you were thoughtful about this. You were conservative. You used imaging. You continued on a non-steroidal. So that is, I think, the ideal first approach before you pivot to the operating room. So even if you end up operating on this child, I think your approach to this, differing a little bit from the adult vitreoretinal surgeon, was appropriate, because you and I both know kids' eyes are not little adult eyes. They are distinctly different.
That's right.
Well, So, Dr. Chan, thank you so much for joining us on your paper. Thanks for excellent imaging. For all of those listening, they can find this in this issue of JVRD. Thank you very much, Paul.
Thank you, Tim.
Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts and Spotify. Visit www.asrs.org/JVRD forum on the ASRS website to learn more. See you soon.